patient undergoes procedure and walks out of the hospital cancer-free in 7 to 10 days of admission. So you can see multiple nodules here. These are all nodules here. And also on the lung surface, you can see some nodules. So when biopsy was taken, it turned out to be a round cell tumor. What we thought was that there were mets from the breast, malignant pleural effusion, but with the thoracoscopy, we could visually see, get tissue and confirm that it is not malignancy. Also gave the diagnosis of tuberculosis for her. Pneumonia, had 3 courses of antibiotics and still spiking fever.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Thank you so much for having me here. So I am interventional pulmonologist. So we do a lot of interventions even in pulmonary medicines, because when we talk about scopies and any kind of procedures, we think of either surgeons or cardiologists and gastroenterologists like that. So even in pulmonary medicine, we have a lot of interventions that we do. So I'll be showing some cases today, and we can see how interventional pulmonology helps in diagnosis and management of patients. So are you able to see my screen?
Yes.
Hello?
Yes.
Yeah. So when we talk about pulmonary medicine or respiratory medicine or DTCD like that, so always respiratory medicine has been a specialty of tuberculosis. Back then also it was all about tuberculosis, and even now tuberculosis presents in very different ways and affects lot of patients. But we have come a long way from here to here. This is how interventional pulmonology suite looks like. It almost is a OT with, you can see it looks like an OT with a lot of gadgets inside. And we have come a long way from here, it being a specialty of tuberculosis with a lot of interventions being done. So this is our current bronchoscopy room at our center. So where we can diagnose any kind of problem in the lungs. So when we talk about respiratory diseases, previously and in most of the centers even now, respiratory diseases can be diagnosed with the help of stethoscopes, with the help of chest x-rays, a very good history and examination of sputum. But when I say interventional pulmonology, do we have to then do interventions or not? Because some patients with all these things, we might not be able to get a diagnosis. And if there is no diagnosis, there is no treatment to be started for these patients. So in some patients, it might be needed that we do interventions to get tissue samples to send for histopathology, or samples for microbiology to get an answer for all the patients who are suffering from diseases and don't have a diagnosis yet. So when I say interventions, is it very new? Interventions, were they done before? Yes, the first intervention was done. You can see the picture here as early as 1890s, where there was a chicken bone aspirated in the lung, and that was removed by a person called Gustav Killian. So when we talk about rigid bronchoscopy, that was the first thing that came. You can see this diagram. Can you see my arrow?
Yes, ma'am.
Yeah, so here you can see a rigid steel tube that is inserted into the airway of the patient called rigid bronchoscopy. So any therapeutic procedures, even now we use this rigid bronchoscope. But do we have to do this invasive procedure when we have to just take a wash or lavage from the affected lung with pneumonia? This becomes very invasive that time. So this is Shigeto Ikeda, who came up with a flexible bronchoscope. You can see how thin it is. It is basically, to tell in simpler terms, it's a tube with camera and light, which helps us, uh, you know, lighten up the airways and also see what is happening inside the airways. So this is called the flexible bronchoscope. Previously, the person who was operating only could see what is happening inside the airways, but nowadays we have all the technology where this can be projected on the screen, so that people around you who are helping you for the procedure also can understand what is happening in the airways and how to help out during the procedure. And from here, the next thing that is going to come up, like how the surgeons have robotics, we also are going to reach the level where we have robotic bronchoscopies, which are already there in different parts of the world. So let us start. After this brief introduction, I would want to say the procedures are divided broadly into pleural procedures and airway procedures. The interventions that we do are either for the diagnosis of pathology in the pleural space or inside the airways. So first case, if we see, this is a 23-year-old male patient, had history of occupational exposure to silica. Patient was a non-smoker with no comorbidities. Presented with complaints of shortness of breath. You can see here on the chest X-ray there is whiteout on the right side. It was pleural effusion and at an outside center pleural fluid was tapped. Here we can clearly see that the fluid is exudate, 80% lymphocyte, so exudate lymphocyte predominant with ADA of 45. In any center, this can be considered as tuberculosis, but nowadays we need more proof. We need histopathological diagnosis, we need microbiological diagnosis to say that it is tuberculosis and also to look for the resistant pattern. But when the facilities are not available, based on the pleural fluid report, we can start on antitubercular treatment. But one catch is, if the patient is responding to tubercular treatment, then it is okay. If not, and there is recurrence of pleural fluid, like in this patient, we'll have to next see what is the cause, because he's not definitely responding for antitubercular treatment. So a CT scan was done. You can see here there is nodular infiltration of the pleura, and then we decided to see what actually is the problem. So what do we do is something called thoracoscopy, where a camera is inserted into the pleural cavity and we can visualize what is happening inside the pleura. This is what we found. This is the diaphragm of the patient. You can see multiple nodules here. These are all nodules here. And also on the lung surface, you can see some nodules. So when biopsy was taken, it turned out to be a round cell tumor. So the clinical clue here is that when the patient is empirically started on ATT and not responding to ATT, next is to see what is happening inside the pleura. That is where intervention or the thoracoscopy helps in achieving a diagnosis. So with thoracoscopy, one is you enter the pleura and see what is happening, what is the abnormality, and it will help us to, it will guide us to take biopsies from the abnormal areas of the pleura properly under vision. We can see where is the abnormal area and take biopsies from that. Second advantage is that when we do thoracoscopy, as much as pleural fluid can be completely removed, we put an ICD, intercostal drainage tube, so that all the fluid gets removed from the pleural surface. Third thing is brushing will be taken, or imprint cytology. That means when we take tissue from there, we rub it on the slide and immediately check under microscope. If there is any malignant cytology and the lung is expanding, we usually spray powder like this called talc powderage. This will get two layers of the pleura together, the visceral pleura and the parietal pleura, and obliterates the pleural space called pleurodesis, so that there is no recurrence of pleural effusion, which usually happens in patients with malignancy. So another thing is, if lung is not expanding due to any reason on table, and we understand that the lung is not going to expand, then this pleural space remains like that and it keeps recollecting. The pleural fluid keeps recollecting. At that point of time, our tube is kept for a long time so that the drainage happens, called indwelling pleural catheter. So you can see we are not only diagnosing, but also therapeutically we are trying to make sure that the pleural space is obliterated with talc pleurodesis, or we can keep a tube like this inside, so it helps in continuous drainage of the pleural fluid and helps the patient with relief of symptoms. This is another case. You can see a 58-year-old female. She had history of breast malignancy 2 years back, which was completely treated. Recently, she had complaints of breathlessness and cough with minimal expectoration. You can see here the left side is completely opaque. There is left-sided massive pleural effusion. With patient having the history of breast malignancy 2 years back, we would think that there is recurrence or pleural metastasis. But just the X-ray, the massive effusion, is it sufficient? Her pleural fluid also was exudate, but did not show any malignant cytology positivity. So next, we took her for thoracoscopy. You can see here, this is how the parietal pleura looks like. But what we see here is lot of nodules which are called sago grain appearance, like boiled sabudana appearance, which is very characteristic of tuberculosis. Then a biopsy was taken which showed necrotizing granulomatous inflammation. And then you can see this is the X-ray post-procedure. The pleural fluid is drained. And good for the patient, it is not metastasis, but it is tuberculosis, which can be completely treatable. So what we thought was that there were mets from the breast, malignant pleural effusion, but with the thoracoscopy, we could visually see, get tissue, and confirm that it is not malignancy. Also gave the diagnosis of tuberculosis for her. So this is about the pleural procedures. When we talk about the airway procedures, what we do is fiber optic bronchoscopy, bronchoalveolar lavage. That means if any pathology is in one part of the lung, we can push saline, and the saline mixes with the cells of the pathological area, and then infected area, and then that fluid is collected back and sent for investigations. If any mass is there in the endobronchial region, biopsies can be taken, and also brushings can be taken for diagnosis. So what are we exactly doing? This is the airway. This is the right upper lobe. This is the right main. This is the trachea, right main bronchus, and the left main bronchus. This is the right upper lobe. This is the right lower lobe. This is the left main bronchus, left upper lobe, and left lower lobe. So till here, we are able to visualize by putting camera and light if any pathology is there inside the airway. So this is how normal bronchoscopy looks like. So this is the airway. This is the carina. This is the right main bronchus, left main bronchus. On the left side, there is the left upper lobe, there is the left lower lobe, and on the right side, there is a right upper lobe here and the right lower lobe. So we can see some pathology in this area. So there is some infiltration. In these cases, we can take biopsies and send for investigations. So when do we do bronchoscopy? Do we have to do bronchoscopy in all patients? No. If patients are having persistent unexplained cough, coughing out blood in sputum called hemoptysis, unilateral wheeze, diaphragmatic paralysis if we are thinking there is a mass in the hilum and then patient is having paralysis, unexplained hoarseness of voice, any recurrent laryngeal nerve involvement because of malignancy, suspected tracheoesophageal fistula, and so on and so forth. And if any patient is having non-resolving pneumonia, it becomes very important to understand what is causing that pneumonia. Is there any endobronchial obstruction or any organism which is not treated like tuberculosis or fungal infection? So when we do a lavage, what we do is first the CT scan or X-ray is seen, and we identify the lobe of involvement, like right upper lobe or left lower lobe. And once we involve this, once we get to know what is the site of involvement, the bronchoscope is navigated to that lobe and wedged into that segment, and we push saline, and this saline mixes with any infected material, and then it is suctioned back and collected and sent for investigations. So here you can see an abnormal area, and this is the forceps that is used, and then biopsies are taken from the abnormal area and sent for histopathological examination. So this is endobronchial biopsies if there are any lesions in the main airway. So this is a patient who had a regular checkup, and on X-ray was found to have a nodule on the right side of the lung, and then CT scan was done which showed a nodule in the lateral segment of the right middle lobe. So what do we have to do next? If we do a CT guided biopsy from here, there is a short chance of pneumothorax, and sometimes there is a chance that there can be bleeding which can go into the main airway. So how do we take biopsy from that? Biopsy becomes very important because it's a speculated lesion. Maybe we have picked up a lung malignancy at its initial stages. So this is called a peripheral pulmonary nodule. So what we do is that we saw the video of the bronchoscopy where we can see there is pink mucosa and there is airway. We can't see exactly if any nodule is there outside the airway. So what is outside the airway can be visualized by use of ultrasound. So what we can see is what is inside the airway, but what is adjacent to the airway can be detected by using ultrasound, and then we can take biopsy from that. This is called endobronchial ultrasound, or we call it EBUS. EBUS are of two types. This is radial EBUS, in which at the tip you can see there is a 360-degree ultrasound that it is rotating. We are screening in one airway. We are not getting the lesion. We'll screen in another airway. This is how the lesion looks like. This is how the mass looks like. Once we have located the mass, this is the guide sheet that is kept, and then brushings are taken from the lesion, and this brush is smeared on the slide, and we can stain immediately, and we can examine the cells on the slide even before the patient is out of anesthesia. And multiple biopsies can be taken from the lesion with the help of this guide sheet. So what did we do with our case? You can see here, what we do first is the CD is loaded into something called navigation system, like how we have the GPS. So this was the lesion that we are talking about. So we'll mark the lesion because airway is also called bronchial tree. It is definitely a tree with multiple branches. So how do we know which branch to go and in which area the nodule is with something called navigational bronchoscopy, where there is a clear cut pathway, like how GPS is there. Once you mark the nodule in the airway, there is a map that is given by the software which will tell you, okay, in these three you have to go into this one. And once you enter that there are multiple branches, in which branch do we have to go is what we look at. So how do we know we are inside the lesion? The latest technology that is there in interventional pulmonology is something called cone beam CT, where our forceps or our biopsy tool can be confirmed that we are inside the lesion by doing a CT scan spin when the patient is in between the procedure. So that is called cone beam CT, which will help us to understand where is the tool, is it inside the lesion or not. So this patient, we did imprint cytology which showed malignant cells. So when we have a mass inside the lung with or a nodule inside the lung, and on the imprint cytology we have malignant cells, or if we had done a CT guided biopsy in this patient, next thing that we have to do is screen the mediastinum and stage the malignancy. Because if the patient is having higher stages of malignancy, patient is not a surgical candidate. But if it is initial stages of malignancy, we can approach the patient with the curative intent by doing lobectomy. So what happened here is that we saw malignant cells, and next day we planned for in the same sitting we did something called mediastinal staging. I'll be showing about that part of EBUS also. Once the mediastinal staging is done, next thing to do is make sure that there is no distant metastasis. So PET scan was done to make sure that there is no distant metastasis, and once we staged it in the initial stages of malignancy, next thing to do is lobectomy. So this patient underwent lobectomy. So you can imagine a patient coming to the hospital, just screens herself and finds to have a nodule. Biopsy is taken on one day, next day PET scan is done. Same sitting staging is done with endobronchial ultrasound, mediastinal staging is done, PET scan is done, patient undergoes procedure and walks out of the hospital cancer free in 7 to 10 days of admission. So this is where the technology is there in interventional pulmonology, how evolved it is. So this is what I was talking about, the latest technology that is called the cone beam CT scan. This is where the patient is lying down on the cone beam table, patient is intubated and ventilated, and we take a CT scan spin around the patient. So that is the baseline CT scan. So if this is the nodule is marked in all three dimensions, axial, coronal and sagittal section. Once this is marked, this coincides with the fluoroscopy when we are doing the procedure. That means here you cannot see where is the nodule exactly. But if it is marked like this is called augmented fluoroscopy. And once we know where is the nodule, we can pass the radial probe, locate the lesion like how we saw in the airways with the 360-degree ultrasound probe. And once that is done, we will pass our forceps and again do a spin and see if again a spin is done like this. And then we will see if our forceps or the probe with which we do biopsy called the cryo probe is inside the lesion or not. And then we take biopsy. So future things are, if patient is not operable in the same sitting, there can be ablation of the tumor cells that can be done. So there is now no difference between the interventional radiologist and interventional pulmonologist, with added advantage that we can prevent a lot of pneumothoraxis. We can control the bleeding very well with the airways. In the same sitting, we can also do mediastinal staging, and we can collect samples for microbiology also called the lavage in the same sitting. Not everything is about malignancy here. We had a patient with chronic liver disease. Patient was spiking fever and was having a left upper lobe cavity. This was post-transplant patient, but not doing well. You can see there is still effusion here. And this was the biopsy forceps inside the cavity, and this turned out to be aspergillus. Another such patient where incidentally detected nodule was there. Patient wanted to go to Gulf region and then had a regular checkup. On X-ray was found to have a lesion in the right upper lobe. This is the lesion here, and you can see the airway here. So if you put a probe, you will get the lesion on the side of the probe. So you can see this is the lesion that is there. And then a cone beam CT scan is done, and you can see the forceps, or this is a cryo probe just next to the lesion. And this turned out to be tuberculosis. So this is early detection of tuberculosis even before patient is having symptoms. There is cavitation, patient starts coughing out infected sputum. This is necrotizing granulomatous inflammation on biopsy and turned out to be tuberculosis. So when we are talking about endobronchial ultrasound, so the radial EBUS till now what we saw, which helps in peripheral nodules in the parenchyma of the lung, is called the radial EBUS. Another variation of endobronchial ultrasound is something called convex EBUS. So this is a 20-year-old female software employee, night shifts, fever with 1 month of cough. On evaluation, on CT scan was found to be having enlarged mediastinal lymph nodes. So this is how it looks like. You can see that it is necrosis. This when patients usually present with a generalized lymphadenopathy, it becomes very difficult to differentiate between tuberculosis, sarcoidosis, lymphoma, and it is very essential to have a diagnosis before treatment. For these patients, we can't just empirically start on tubercular medications. So when enlarged lymph nodes are there, previously mediastinoscopy was the only option, which is very, very invasive. Now what we have is something called endobronchial ultrasound. Like if there is any cervical lymph node that we are having in the neck, what we do is put in a needle, put in suction, and take multiple jabs from that region and make slides and see on cytology. The same thing we are going to be doing in the mediastinum. So here if we see, there are so many stations of lymph nodes, and it becomes very important to diagnose them before starting the treatment. So from inside, when we see, we can see only the airway from inside, like I said. So whatever is adjacent to the airway, we will be putting ultrasound called EBUS, but this is called convex EBUS. So what exactly we do is, you can see in this video, this is the bronchoscope, and this is something called endobronchial ultrasound. So with the help of ultrasound, screening is done on the wall, and here is the lymph node. Once we locate this lymph node, the balloon is inflated here with normal saline, because water is good conductor for transmission of the ultrasound waves. And once the lymph node is located, you can see the needle here, which will be passed inside the lymph node, and multiple jabs are made like this with the help of suction, so that the cells which are inside the lymph node will be aspirated, and immediately the slide is made, and then we can see what cells are there and what is the diagnosis, and if the tissue is enough to get because now is the era of NGS, PDL1, IHC, so we need a lot of tissues for a lot of investigations. So we make sure that the tissue or the material that we are getting is sufficient for all these tests. So also when blindly samples are taken from lymph nodes, we don't know which is the soft part, which is the hard part, and also we don't know the vascularity. So the Doppler option is one thing, and also like how we palpate the lymph nodes and we say that it is soft or hard lymph node. There is something called elastography, which gives us a fair idea if the lymph node is hard like this, if it is blue, or if it is soft or necrotic lymph node, if it is green or red in color. So we usually try to take samples from the harder part, because if you take from the necrotic part, you will just get necrosis on the slide or the diagnosis. Another thing always my colleagues used to tell was, in pulmonary medicine, the tissue that you get is not enough. So the tissue used to be the issue before, because whatever samples we used to take, they were saying that it is not sufficient to conduct all the tests. So something called cryobiopsy came into place, where this probe that we are seeing inside the lymph node, will have a metallic tip at the end which freezes. So once it freezes the tissue around it, and then it can be plucked out. So when we do this kind of biopsies, it is not just little bit of liquid that we are aspirating from the lymph node. It is almost like it is actually a biopsy, and you can see how much tissue that we get from the lymph nodes each time the biopsy is done. This is very interesting case of non-resolving pneumonia. This patient has had pneumonia, had 3 courses of antibiotics, and still spiking fever. And this was consolidation in the left lung. So you can see in the CT scan here, this consolidation is specifically affecting the lingular segment. So once we know the segment, we have to see if it is tuberculosis, if it is fungal infection, why it is not resolving with antibiotics. Is there any obstruction to the airway from inside in the lingula? So what we have to do at this point is bronchoscopy and go inside and see what is happening. So this is bronchoscopy. You can see what is happening. The airway has to be open like this, and we should be able to see the division inside the airways, but this is completely plugged. So what is it plugged with? Initially, to be honest, even I thought it was most probably a malignant cauliflower like growth, but on closer examination you can see there is difference between this part and this part. That was when here this brownish color, that was when I thought, okay, most probably this might be a foreign body or something. So what we usually do is that we pass a balloon. We try to get this tissue out first. There's a cryoprobe I was talking about. This part freezes, and the tissue attached to that also freezes and gets attached to the probe, and you can see a piece here. So that suggests that it is most probably a foreign body. And what tissue around it is granulation tissue, and tissue is the one which bleeds like this when you touch it. So what we usually do is we put in a balloon, inflate it, and pull out to see if there is movement of the foreign body. And here, yes, you can see that there is a foreign body which was stuck in the lingula. Mostly foreign bodies go onto the right side because the right main bronchus is in continuation with the trachea, but somehow it was in the lingula, and when there is a foreign body, it has to be extracted out of the airway. And this is the basket that we usually use to hold the foreign body and get it out of the airway. So here you can see the granulation tissue which had grown, and this is the superior and the inferior lingular branches. And what we saw that time in the CT scan was post-obstructive pneumonia because of a foreign body inside the lingular segment. So this granulation tissue, usually once the foreign body is removed, it goes off. We don't have to do anything and just leave it there and take a lavage and send it for investigations. So this patient, you can see there is an endotracheal tube. This is a patient with ICU. A call was given saying patient's oxygen requirement is increasing, ventilatory parameters are worsening, and then this chest x-ray, previously this was not there, and chest x-ray is showing collapse of the left lung completely. Here you can see mediastinal shift to the left side, and there is collapse of the left side. So what might be causing this collapse? So we had to put in a bronchoscope and see. Usually in ICU patients, we see mucus plugs or pus plugs blocking the airway. So here we can see this is the right side which is completely open, and left side which is having pus. So what we do is just suction out the mucus plug or the pus plug, and this is very therapeutic because once it is suctioned out, you can see the post-bronchial toileting that was on the right side, but if you see on the left side, the airway is completely open, left upper lobe, left lower lobe, and you can see the lung has completely expanded. Another such case was a patient who had complaints of hemoptysis, and patient had left-sided lung collapse. You can see that the trachea is shifted to this side and complete collapse of the left side. Again, what might be the cause? There might be a foreign body, there might be a tumor, there might be a pus plug, but with the history of patient having hemoptysis, most probably it's a airway clot. So this you can see how the clot is inside the airways. There's a left side which is a bit open here, but patient was having active hemoptysis, and that blood had clotted and it was completely on the right side. So this blood clot usually will not come with suction or with the help of forceps. That is when we use this freezing probe called the cryoprobe, where once it freezes, it holds on to the clot and it can be removed slowly. So again, sometimes the entire clot comes out with the help of this cryoprobe, but sometimes it takes time and the pieces come bit by bit like this, and then yeah. So I'm sorry, this video is not playing, but yeah, okay. So you can see that slowly, bit by bit, there are different sized probes also, and once we start clearing the airways, this is the right lower lobe, this is the right upper lobe. So this entire thing was full of clot. So the clot always take the shape of the bronchial tree. So it is like a cast. So you can see how the airway clots are, and once the clots are removed, you can see that the lung has completely expanded. So in the same sitting, we take lavage also and send for investigations to see if it was tuberculosis, if it was fungal infection, and what was the cause for such kind of a bleed in that patient. So this is a patient
from the Division of Interventional.
So this is a patient who had history of adenocarcinoma and was already on osimertinib since 2 years, and patient had complaints of dry cough and shortness of breath. And a PET scan was done. You can see here, this was the previous PET scan, and here you can see that there is a new lesion in the right upper lobe and looks like there is a growth. And you can see this is the left main bronchus, which is completely free, and this is the right main bronchus. So this is a malignancy patient. Should we just leave her alone and not do anything? Because if you see here, what we are doing is something called tumor debulking. What we want to do is remove this tumor so that the right side airway opens up. Otherwise, what happens in the PET scan, we saw that the lung was open, but after some time, as the tumor grows, it completely obstructs the airflow to the right side, and then the right lung will completely collapse, and patient starts having breathlessness. This is a procedure done with palliative intent. We just want to improve the quality of life of the patient, and we are not looking at any curative kind of procedure here. So what we are using here is something called an endobronchial snare. So it we loop the snare around the tumor, and once it is looped, we slowly start closing, and in between the loop, the tumor is cut, and the part of the tumor that is cut can be completely extracted out of the airway. Again, this is the cryoprobe being used because it will freeze and hold the tissue. So this is, you can see it is freezing and holding the tissue, and you can see the tissue has slipped away and this is a cut part of the tumor that we cut using the endobronchial snare. So once this part of the tumor is cut, you can see that the right upper lobe is free, and slowly, bit by bit, chunk by chunk, the tumor is removed. And once the tumor is removed, you can see this, the right side, which was completely filled with tumor. This is the right upper lobe, this is the right middle lobe, and this is the right lower lobe. So here we can understand that the tumor has come from this place, it has grown from this place. This is the tumor bed. So to prevent the recurrence of the tumor, we burn it. This is something called argon plasma coagulation, where argon gas is used and electricity is converted into heat energy, and the base is burnt or charred so that we can prevent the recurrence of tumor. This is another patient with tumor, but here we decide to do debulking. Here you can see the right main bronchus. This is the left main bronchus, which is completely filled with tumor. So here this patient again had, so we saw a case of mucus plug, we saw a case of clot which caused the collapse of the lung, and then we saw a case of tumor without the collapse of the lung. Here is a patient with tumor causing the lung collapse, and this is the right side and this is the left side. So the left side is completely filled with tumor, and what we do is try to suction the tumor and remove the tumor slowly, bit by bit. And you can see here there is complete infiltration of the wall. There is, if you touch, it is bleeding here. So the wall is completely infiltrated by the tumor tissue, and then slowly a pathway is made to reach the right upper lobe. This is all completely infiltrated. So there's a right upper lobe and the right lower lobe. And if this patient is left like this, tumor is again going to regrow. There will be a lot of collection of infected material also, and then again the lung will collapse. So how do we keep the left side of the airway open becomes a very important question here. So what we do is, because we know it is malignancy, here you can see this is a metallic stent that is being inserted to keep the airway open. So this is the same endobronchial view where we are seeing how the stent opens, and you can see this is a covered metallic stent. So how we have stents to keep the cardiac vessels open, we also have stents to keep the airway open, and metallic stents are there and silicone stents are there. When there is malignancy, we usually insert metallic stent, and this is the left upper lobe and the left lower lobe, and this which the left main bronchus, which was completely closed, is now kept open with the help of the stent. So how is the lung after keeping the stent? Let us see the chest x-ray. You can see here the lung has expanded, but still there is some opacification here. And on the ultrasound, it was found that whenever there is collapse, it can be associated with effusion because of the negative pressure called collapse effusion. And here, we inserted a pigtail, and once the pigtail was inserted, the lung is open, oxygen requirement decreases, the left main bronchus is kept open with a stent, patient was shifted out of the ICU. So this is the palliative care we are talking about to improve the quality of life of the patient. This patient is very interesting case where patient had a history of breathlessness, noisy breathing, there is stridor, cough, and also mild hemoptysis. Patient had blood tinged sputum. This is the bronchoscopic video. You can see this is the mass which is moving up and down with every breath the patient is taking. A bronchoscopy was also done at an outside center, and patient was told that you're going to die very soon because you're having a tumor in your lung. And then this is how it looks like. We use the same electrocautery snare that we used previously, loop around the tumor and cut the tumor at the base. And here, for a patient who was told is not going to live for more than a few weeks, luckily this turned out to be just a squamous papilloma, which is a benign tumor of the airway. And this at the recent bronchoscopy is just a small scar, and he is still under follow-up to see if any recurrence is there. So these are all the therapeutic procedures which are done either as a with a curative intent or with a palliative care to increase the quality of life for patients. Here we have chest x-ray. You can see bilateral infiltration here in this baseline chest x-ray, and this is a CT scan of the patient. Usually the lung looks like this, completely black on both the sides, but here what we can see is whitish infiltration of the lung. This pattern in the CT scan is called crazy paving appearance. This is another interventional procedures which is a therapeutic procedure. This condition is called pulmonary alveolar proteinosis. So what happens here is the surfactant that is produced does not get damaged or degraded because there is an issue with the metabolism of the surfactant in the lung. So over many years, whatever surfactant is produced does not get metabolized and it starts collecting in the lung. So lung is completely filled, the alveoli is completely filled with surfactant protein called pulmonary alveolar proteinosis. At one level, both the lungs are fully filled with this material, and then you have to literally wash out this material from both the sides of the lung, called whole lung lavage. You have to lavage the entire lung. You can see at the first sitting, we lavage the right lung. In the second sitting, we lavage the left lung. So this is the amount of fluid that was needed to wash out these lungs. And in one of the images, you can see a line here below which the white color is more. That is all the protein content that settles down, and you have to wash till the fluid becomes clear. So you have to wash all the content out. So this is another case which is a very interesting case because this patient had a road traffic accident. Patient was intubated, patient was on tracheostomy, and how many ever times decannulation attempts were made. Patient was tried to remove out of the decannulation, it was not happening, and patient was worsening immediately, and tracheostomy had to be put back. So when we thought we'll see what is the reason for patient not being able to decannulate, what we saw was a granulation tissue. So any foreign body inside inside the body will actually create a reaction where granulation tissue is formed. And this granulation tissue, again using this snare or the electrocautery snare, can be cut. So what we did is loop the snare around the granulation tissue and then cut it out and remove it. And you can see here the granulation tissue, and below the granulation tissue is the tracheostomy tube here. So above the tracheostomy tube there was granulation tissue. That is why whenever the tube was removed, there was obstruction in the upper airway because of the granulation tissue, and then the patient could not be decannulated. So what we do is remove bit by bit using this cryoprobe. Once the major chunk is cut using the snare, the cryoprobe is used to pluck it out bit by bit. And once everything is removed, what we see down below is the tracheostomy tube. Once all the granulation tissue above the tracheostomy tube is slowly removed, the white one is the tracheostomy tube. What we do is slowly pull out here the tracheostomy tube and visualize the airway from the vocal cords till the carina. So you can see here the scope is being passed. You can see the carina there. You can see the end of the tracheostomy tube here, and above that was the granulation tissue, which is now cleared. And this is something called balloon, which is filled with normal saline, which is used to dilate the airway. So it is called CRE balloon dilatation. Once the dilatation is done and the walls are flattened, you can see how the airway is. So once we achieve this airway, patient can be decannulated on table, and the patient was told that he has to be on tracheostomy lifelong by seeing what is happening above the airway and just clearing this small blob of tissue. You can see how is the airway, and this tracheostomy stoma is closed, and the patient can breathe through nose, and is completely free of tracheostomy tube. So do we have always granulation tissue above the tracheostomy? No. Sometimes we also have. So this is one patient who had history again of road traffic accident, history of intubation. After COVID, we see a lot of post-intubation tracheal stenosis happening. Here, this patient presented in respiratory failure with severe acidosis and CO2 narcosis. And then a small bronchoscope. We have different sizes of bronchoscopes, and a small bronchoscope is passed through the vocal cords here, and you can see the airway is completely narrow. So it is post-intubation tracheal stenosis. So what we do in these patients is dilate the area of stenosis using the CRE balloon, that is the balloon used for dilatation, and also mechanical dilatation using the rigid bronchoscopy barrel, the steel barrel that we initially saw. What we do is serial increase in the diameter of the airway, and when we feel like the cartilage is damaged and the airway is not going to hold, then we place a stent. So this is not the same metallic stent we saw in the malignancy patient. This is something called silicone stent, which is temporary and which is usually removed after 1.5 to 2 years. That is a time which we give for the airway to remodel so that the airway holds on its own without collapsing. Because when tracheostomy is done, sometimes the cartilage is damaged and the airway will not hold. So that time we'll have to insert a silicone stent to actually keep the airway open. So this method of deploying the silicone stent under vision was developed from our hospital and was published as a case series. Another important thing is taking biopsy from the lung parenchyma. So any interstitial lung disease requiring a biopsy, previously surgeon had to do a VATS procedure, a surgical procedure to get a small chunk of tissue from the lung parenchyma to establish diagnosis in patients. This is one such interesting case. You can see in the CT scan here, this is all interstitial lung disease kind of changes. But what is very peculiar here is right side is more involved than the left side. Usually in interstitial lung disease, we see symmetrical involvement of both the lungs, and PET scan showed that this area was lighting up. So when a transbronchial lung biopsy was done, this turned out to be a bronchoalveolar cell carcinoma. So how do we do transbronchial lung biopsy? Is that this is the cryoprobe under fluoroscopy. Here you can see here there is a balloon that is kept, and this is the cryoprobe that is pushed, and once we feel resistance, that means we are touching the pleura, we have to pull back a little bit and freeze for 3 seconds. So this is reconfirming that we are not very near the pleura, and once we freeze the probe for usually around 3 seconds and we pull back, and there will be a part of tissue that is attached to the end of the probe. So you can see here, so instead of doing a big surgery to get a small part of tissue, what we do is something called cryobiopsy like this, where we take around 2 to 3 samples from the affected part of the lung and send it for histopathological. So you can see the amount of tissue that we get from the cryobiopsy of the lung parenchyma, which is usually sufficient for all kind of diagnosis. This is a patient with CKD, and patient had a very interesting CT. Patient was having cough, breathlessness, and fever, and you can see the CT scan. There are multiple nodules, starting from a nodule in the right upper lobe here, and then here, and you can see small studded nodules in both lungs. You can see the nodules becoming more and more as we are going to the bases of the lungs. So when we do bronchoscopy, you can see there is a endobronchial mass inside the airway. You can see a mass like this, and then a biopsy was taken. So what we used here was cryoprobe. Again, you can see here, this is the metallic part, it is freezing, and when we pluck out, a part of tissue comes along with that, and then we rub on the slide. Even before the patient is out of anesthesia, we usually stain the slide and look for diagnosis, and here we could all see was cryptococcus like organism, and this was a very interesting case of pulmonary cryptococcosis in a patient post renal transplantation. And how important it becomes to visualize the airways is that this is a very young boy with recurrent infections, recurrent pneumonia, left lower lobe pneumonia, and the reason was not found out. So when we have patients with recurrent pneumonia, persistent cough, what we do is go inside and see what is happening, and also take sample from there to see what is happening. So this was the kid, and slowly when the bronchoscope was pulled out, there was some breach in the posterior wall. So you can appreciate that there is a small ditch in the posterior wall, and it is a hole here. So there is a fistula, and every fistula, a mostly it is tracheoesophageal fistula. So it becomes very important to see the tracheal end of it and also the esophageal end of it. So there's an opening here, and then I push the scope into the esophagus, and you can see an opening here. So this is the anterior wall of the esophagus, and what we saw here was an opening in the posterior wall of the trachea. So this was a very interesting case of tracheoesophageal fistula that was causing the recurrent pneumonia
from the Division of Interventional Pulmonology.
So lot of kids usually try to pick up something on the floor and try to put it in the mouth, and sometimes aspirate those things inside the airways. So here is one such kit where you can see there was history of witnessed aspiration, and you can see that left side is completely clear, whereas on the right side, this is the left side, and on the right side we can see there is a organic foreign body. So usually these foreign bodies go inside the airways, and because they are organic, they start absorbing fluid from the airways and start swelling inside the airways. So what we do with these foreign bodies is use the basket like the last adult patient where we saw the foreign body, and grasp the foreign body and make sure it falls inside the basket, and slowly extract the foreign body out of the airway. So sometimes it becomes an emergency procedure because organic foreign body swells and it goes as a small piece and becomes a big piece and cannot be retrieved outside the trachea sometimes. And also it causes a lot of mucosal edema, and kids can go into respiratory distress. 11-month-old baby. I don't know how this pin went inside, but this was a hijab pin inside the airway of the kid. So here you can see. So when the pin is there, the kid starts coughing because of irritation, and when the sharp end is there, usually because of repeated coughing, the sharp end gets embedded inside the mucosa like this in the submucosal region. So it becomes very challenging. We can't pull out the needle from here because the big end, the green end that is visible here, gets stuck here. So we have to release the pin from its attachment towards the mucosa. We hold the pin usually and push it down so that it gets released outside the airway. And once it is released like this, we use the forceps to protect the sharp end and hold the foreign body. And slowly, once it is held with the forceps, it is slowly pulled outside. You can see the tip of the needle of the pin here, and slowly it is pulled outside the airway. So this is a therapeutic procedure. So removing a foreign body is a therapeutic procedure. This is another case, 26-year-old male. He had history of organophosphorus poisoning, for which he was intubated, extubated, and then suddenly presented with respiratory distress. You can see this patient here. Patient is tachypneic, tachycardic, diaphoresis, in respiratory failure, almost going in for carbon dioxide narcosis. So here the patient was not even tolerating the NIV. So can we do a bronchoscopy here? Definitely patient will not tolerate the bronchoscopy. Mostly this patient, the CT outside was showing stenosis. Like I said, after COVID, lot of post-intubation tracheal stenosis we are seeing. The area where the cuff of the ET tube has been there for many days during the intubation, there is edema, there is inflammation, which heals with fibrosis. And once it heals with fibrosis, the lumen of the trachea becomes very small, called the stenosis. So at this point of time, we did not know where is the level of stenosis. Can we do a tracheostomy? Because sometimes if you do tracheostomy at the level of stenosis, it becomes catastrophic. So here you can see that the patient is completely unstable to take up for stenosis dilatation also. So with that patient being so sick, as we saw in the video, stabilization of the blood gases becomes very important, because once the anesthetic agent is given, the patient might even collapse. So at this point, the team completely decided to go for VV ECMO, called the veno-venous ECMO. And once the patient was put on VV ECMO and the blood gases stabilized, we took the patient to OT, and you can see how is the lumen of the trachea. This is the lumen with which the patient was actually breathing. That is why he was so sick. And there was near complete obstruction of the trachea. And once the stenosis was seen and dilatation was done and a stent was kept, the patient was decannulated on table because the central airway obstruction is taken care of. There is no need for assistance for ventilation. And then the patient was decannulated on table and shifted to ICU. This is the video of the patient walking around after coming in that stage, after the patient was discharged. You can see him just walking outside. He came to emergency with respiratory failure and CO2 narcosis. So I've been talking about metallic stent, airway stent, silicone stent, and everything. These are all the stents that we put in the airways, depending upon what is the indication. This is a silicone stent. This is something called 3D stent, which takes the shape of the airway. This is the hourglass stent. This is something called dynamic stent. But now what we have is something, so this is a young lady. So like I said, tuberculosis has been presenting in different ways. And this is the right main bronchus, and this is the left main bronchus. So even tuberculosis causes stenosis of the airway. You can see there is no opening of the airway at all, and airway is collapsing on application of suction. So left lung will be completely collapsed in these kind of patients because there is no airway at all for the air to pass. And this is something called biodegradable stent, which is inserted into the airway after dilatation, will hold the airway open and gets integrated into the airway wall. So this is the left upper lobe and this is the right lower lobe below. and we have the biodegradable stent in place. And because it has to degrade after few weeks, this stent degrades and becomes something like this. So what we have in diagnostic advances is, when we take a biopsy from any patient, usually what we do is send for histopathology, and usually the histopathology takes 5 to 7 days depending upon the center. So this is a piece of the biopsy. This is something called a positively charged mesh that we receive the biopsy in, and this is something called, I'm sorry, I'm not able to play this video, but something called confocal laser microscopy, where even before the patient is extubated, we have a histopathological diagnosis. Means we load the tissue inside something called confocal laser microscopy. I'm sorry, I'm not able to play that video, but usually with the help of laser, it forms an image which looks something like this immediately as soon as we, like how we do cytology staining. This is nothing but histopathology, which is done immediately, called rapid on-site histopathological evaluation. So even before the patient is out of anesthesia, we have a histopathological diagnosis, and also we understand if the tissue is sufficient for all the tests that we want to do or not. And with the histopathological diagnosis, there is no need to wait for 5 to 7 days for the reports to come and the treatment to be started. We can start the treatment immediately as soon as the patient is stable out of anesthesia. So we have seen robotic surgeries where huge arms are there in the OTs of the surgeons, but this is how robotic bronchoscopies look like. Something like a joystick that is moving the bronchoscope inside the airways like this, and the needle is passed to take biopsies from there. And this is our operating theater. This is something called the cone beam CT, and this is where the biopsies are done from the peripheral lesions. And this is our simulation center. So nowadays the training is all about practicing the procedures multiple times on the simulators, learning how to do the procedure, observing the procedures, and then going for the actual procedures on the patient. So now pulmonology has changed so much, and interventional pulmonology itself has changed so much, that with these kind of mannequins you can perfect your skills before observing or before doing the procedures on the patients. I conclude by thanking my mentors and my IP team, and thank you Medflix for having me here. If anybody is interested to see more such procedures, maybe you can see them on my social media handles. Thank you so much.
Thank you so much, ma'am, for your presentation. Can you please stop sharing?
Yeah.
And we've received a lot of appreciative comments as well as many questions as well. I'll take them up one by one.
Yes.
Is there any finding can we expect in cases of tracheoesophageal fistula on X-ray?
X-ray usually, because whatever we are eating is entering the airway, so we'll have only pneumonia-like changes in the chest X-ray. So the patients usually will keep having pneumonia, which is recurrent, which might respond to antibiotics for a few days, but again the aspiration keeps happening. So maybe there might be change in the site of the pneumonia, but usually there is just consolidation or non-homogeneous genus opacity, like we call it, that is seen on the chest X-ray.
Dr. Gupta has asked, what is the primary aid for foreign body in respiratory system?
Aid as in?
I think, ma'am, the most, like the first diagnostic test that we would
do. So usually chest X-ray gives lot of clue, because if the airway is obstructing completely the left side or the right side, depending upon the site of obstruction, one is the lung will collapse on that side if there is no aeration. But another thing is something called ball valve mechanism, where air keeps going inside that side and air doesn't come out. So we usually see like hyperinflation of that side. So both these will give us a clue that there is a possibility of foreign body.
Ma'am, what are the chances of iatrogenic pneumothorax during any of these procedures?
Yeah. So when we see peripheral nodules that I was showing when we are doing cone beam CTs, with more than over 200 to 50 cases, we have had zero pneumothorax. So because we know we are inside the mass of the lesion. And when we talk about transbronchial lung cryobiopsies, there is chance of pneumothorax. But if we make sure that we are not touching the pleura, we are touching the pleura and coming back and then freezing and taking biopsies, usually pneumothorax chances are very less. But with less chances also, we usually keep our chest tube ready just in case for each and every case. But we have we have put a chest tube only in one such patient of lung biopsy.
Yes. Is there any important role of pulmonary angiography specific for undiagnosed cases?
Okay, so two types of angiography we can, what kind of CT scans we usually do is, if we are suspecting any mass or if we are suspecting any mediastinal lymph nodes, we usually go for contrast enhanced CT scan or the CECT. But if we are looking specifically at pulmonary pathology like a thromboembolism, we go for pulmonary angiogram. So it more delineates the pulmonary arteries. And if we are looking at massive hemoptysis patients with lung damaged and we think that it is because of bronchial arteries hypertrophy, which usually come from the aorta, we go for thoracic aortogram. So these are the different types of contrast CTs that we can do for diagnosis.
The next question, ma'am, complications expected during the use of pulmonary.
Yeah, so when we use a snare, what happens is snare is like a loop and if there is a foreign body or something, a tumor or something, so the snare loops around the tumor, and then basically it's like the snare loops around the tumor and we start closing it, and once the base reaches, we have to start cutting and coagulating. So the electricity has to pass and we are cutting through the tumor and we have to coagulate the base at the same time. So two complications that can occur is the current might not pass if the connections are not proper and you can just cut through the tumor without the electricity being passed. So that will just cut without coagulating and bleeding can happen. So we have to check all our instruments before that it is working. There is a spark coming out. It is working properly before we use it to loop around the tumor.
Ma'am, one last question.
Yes.
Can we do ablation? Can we do ablation transbronchially?
Yes. So what happens is, first thing, when there is a nodule, let us say right upper lobe nodule, first we navigate, go to the nodule, we take biopsy. So once we take biopsy, that specimen is rubbed on this slide, we see under microscope. Now let us say it is malignancy. Next thing to do is staging. When we are doing staging, sometimes PET is already done from before. So we know what is the lesion and there is no distant metastasis. And that time, even if PET is negative, we have to do mediastinal screening and mediastinal staging. So now that we know that the N2 lymph nodes, N3 lymph nodes are not affected, next thing to see is the patient surgical candidate. But if patient is having multiple comorbidities and very bad COPD, then in the same sitting, that small nodule can be ablated. It's called radiofrequency ablation.
Okay. Thank you so much, ma'am. That answers all our questions. Yes, sir. I think there's one last question. Do we
No problem at all.
Is it necessary to stop antiplatelets before any of these procedures?
Okay. So when we do EBUS like we saw, we are just using a very small needle which is like 21-22 gauge. And there are papers which say that even if the patient is on clopilate also, it is okay to do procedures. When we have a mass endobronchially, or when we are taking a transbronchial lung cryobiopsy or the parenchymal biopsy, or biopsy from any nodule inside the lung, we usually tend to stop the clopidogrel, at least 5 days before the procedure. And if the patient is on aspirin, usually 1 day before the procedure, we stop it.
Yes, ma'am. I think those are all our questions. Thank you so much, ma'am, for your excellent presentation and answering all our questions.
Thank you so much for having me.